Throat and thorax anatomy and conditions. The anatomy of the throat includes the pharynx, larynx, trachea, and esophagus. The pharynx is a membrane-lined cavity behind the nose and mouth connecting them to the esophagus. The larynx is a hollow muscular organ forming an air passage to the lungs and holding the vocal cords in humans. The trachea is commonly known as the windpipe. It is a tube of about 4 inches long and less than an inch in diameter in most people. The trachea begins just under the larynx and runs down behind the breastbone or sternum. The trachea then divides into 2 smaller tubes called bronchi, one bronchus for each lung. The trachea is composed of about 20 rings of tough cartilage. The back part of each ring is made of muscle and connective tissue. Moist, smooth tissue called mucosa lines the inside of the trachea. The trachea widens and lengthens slightly with each breath in, returning to its resting shape with each breath out. The esophagus is a tube that carries food, liquid, and saliva from your mouth to your stomach. You may not be aware of your esophagus until you swallow something too large, too hot, or too cold. You may also become aware of it when something is wrong. The ribs partially enclose and protect the chest cavity, where many vital organs, including the heart and lungs, are located. The rib cage is collectively made up of long, curved, individual bones with joint connections to the spinal vertebrae. At the chest, many rib bones connect to the sternum via costal cartilage, segments of hyaline cartilage that allow the rib cage to expand during respiration. Although fixed into place, these ribs do allow for some outward movement, and this helps stabilize the chest during inhalation and exhalation. The human rib cage is made up of 12 paired rib bones. Each are symmetrically paired on a right and left side. Of all 24 ribs, the first 7 pairs are often labeled as true. These bones are connected to the costal cartilage, while the 5 other false sets are not. 3 of those connect to non-costal cartilage, and 2 are deemed floating, which means they only connect to the spine. While there are some cases of minor anatomical variation, men and women in general have the same amount of ribs. A differing rib count between the genders is largely a medical myth. The manubrium is the upper portion of the sternum, by the first rib. The tubercle is much more prominent in the upper than lower ribs. The angle of the rib, or the costal angle, may both refer to the bending part of it and the prominent line in this area, a little in front of the tubercle, the body of the sternum, commonly called the breastbone, and the xiphoid process, or the little projection at the bottom of the sternum. The muscles of the thoracic region include the superficial pectoralis major and the deeper pectoralis minor. We can touch and feel the pectoralis major, and it is important to movement. The pectoralis minor is underneath the pec major and can assist with breathing. The rectus abdominis is superficial. In people with low body fat, the bellies of the rectus abdominis can be viewed externally and are commonly referred to as a 4, 6, or 8-pack, depending on how many are visible, although 6 is the most common. While it looks impressive, the rectus abdominis does not contribute to core strength as much as the other muscles do. The transverse abdominis muscle is a muscle layer of the anterior and lateral abdominal wall which is deep to the internal oblique muscle. It is thought by most fitness instructors to be a significant component of the core. The internal oblique muscle is a muscle in the abdominal wall that lies below the external oblique and just above the transverse abdominis muscle. The internal oblique performs 2 major functions. First, as an accessory muscle of respiration that acts as an antagonist to the diaphragm, helping to reduce the volume of the chest cavity during exhalation. When the diaphragm contracts, it pulls the lower wall of the chest cavity down, increasing the volume of the lungs, which then fill with air. Conversely, when the internal obliques contract, they compress the organs of the abdomen, pushing them up into the diaphragm, which intrudes back into the chest cavity, reducing the volume of air, filling the lungs, producing an exhalation. The external oblique muscle is the largest and most superficial or outermost layer of the 3 flat muscles of the lateral anterior abdomen. The external oblique functions to pull the chest downwards and compresses the abdominal cavity, which increases the intra-abdominal pressure as in the Valsalva maneuver. It also has limited actions in both flexion and rotation of the vertebral column. One side of the obliques contracting can create lateral flexion. In human anatomy, the thoracic diaphragm, or simply the diaphragm, is a sheet of internal skeletal muscle. It extends across the bottom of the thoracic cavity. The diaphragm separates the thoracic cavity containing the heart and lungs from the abdominal cavity and performs important functions in respiration. During inhalation, the diaphragm contracts and moves in the inferior direction, thus enlarging the volume of the thoracic cavity. This reduces the interthoracic pressure. In other words, enlarging the cavity creates a suction that draws air into the lungs. Cavity expansion happens in two extremes, along with intermediary forms. When the lower ribs are stabilized and the central tendon of the diaphragm is mobile, a contraction brings the insertion, or the central tendon, towards the organs and pushes it lower in the cavity towards the pelvis, allowing the thoracic cavity to expand downward. This is often called belly breathing. When the central tendon is stabilized and the lower ribs are mobile, a contraction lifts the organ or the ribs up towards the insertion or the central tendon, which works in conjunction with other muscles to allow the ribs to slide and the thoracic cavity to expand laterally and upwards. When the diaphragm relaxes, air is exhaled by an elastic recoil of the lungs and the tissue lining the thoracic cavity. Assisting this function with muscular effort, called forced exhalation, involves the internal intercostal muscles used in conjunction with the abdominal muscles, which act as an antagonist paired with the diaphragm's contraction. The diaphragm is also involved in non-respiratory functions, helping to expel vomit, feces, and urine from the body by increasing the intra-abdominal pressure, and by preventing acid reflux by exerting pressure on the esophagus as it passes through the esophageal hiatus. Intercostal muscles are several groups of muscles that run between the ribs and help form and move the chest wall. The intercostal muscles are mainly involved in the mechanical aspect of breathing. These muscles help expand and shrink the size of the chest cavity to facilitate breathing. There are three principal layers. The external intercostal muscle aids in quiet and forced inhalation. They originate on ribs 1 through 11 and have their insertion on ribs 2 through 12. The external intercostals are responsible for the elevation of the ribs and bending them more open, thus expanding the transverse dimension of the thoracic cavity. The internal intercostal muscles aid in forced expiration. Quiet expiration is a passive process. They originate on ribs 2 through 12 and have their insertion on ribs 1 through 11. The internal intercostals are responsible for the depression of the ribs and bending them inwards, thus decreasing the transverse dimension of the thoracic cavity. The innermost intercostal muscle, the deep layer of the internal intercostal muscle, which are separated from them by a neurovascular bundle. This is then in turn composed of the transversus thoracic muscle, the sternal costal muscle, and the subcostalis muscle. Superficial muscles have a slightly different function than do deep muscles. In general, superficial muscles are visible, bulky, and provide dynamic movement. In contrast, deep muscles are usually much less visible, much less bulky, and provide a stability to the joints and/or the core. The heart is located under the sternum and ribcage, slightly to the left. The purpose of the heart is to pump blood through the blood vessels to the circulatory system. Blood provides the body with oxygen and nutrients and also assists in the removal of metabolic waste. The heart is made up of cardiac muscle. The heart has 4 chambers, 2 upper atria or receiving chambers and 2 lower ventricles, the discharging chambers. The atria opens into the ventricles via the atrioventricular valves. The heart pumps blood through the body. Blood low in oxygen from the systemic circulation enters the right atrium from the superior and inferior vena cava and passes to the right ventricle. From here, it is pumped into the pulmonary circulation through the lungs where it receives oxygen and gives off carbon dioxide. Oxygenated blood then returns to the left atrium, passes through the left ventricle, and is pumped out through the aorta to the systemic circulation, where the oxygen is used and metabolized to carbon dioxide. In addition, the blood carries nutrients from the digestive tract to various organs of the body, while transporting waste to the liver and kidneys. Normally, with each heartbeat, the right ventricle pumps the same amount of blood into the lungs as the left ventricle pumps into the body. Veins transport blood to the heart and carry deoxygenated blood, except for the pulmonary and portal veins. Arteries transport blood away from the heart and, apart from the pulmonary vein, hold oxygenated blood. Their increased distance from the heart causes veins to have a lower pressure than arteries. The heart contracts at a resting rate close to 72 beats per minute. Exercise temporarily increases the rate, but lowers the overall resting heart rate in the long term, which makes it good for heart health. Cardiovascular disease is the most common cause of death globally and accounts for 30% of all deaths. Of these, more than 3/4 follow coronary artery disease and stroke. Risk factors include smoking, being overweight, poor exercise routines, high cholesterol, high blood pressure, and poorly controlled diabetes, among other conditions. The lungs are the primary organ of respiration in humans. Their function in the respiratory system is to extract oxygen from the atmosphere and transfer it to the bloodstream, and then release carbon dioxide from the bloodstream into the atmosphere in a process of gas exchange. In humans, the primary muscle that drives breathing is the diaphragm. The lungs also provide airflow that make vocal sounds, including human speech, possible. Humans have two lungs, a right lung and a left lung. They are situated within the thoracic cavity of the chest. The right lung is bigger than the left, which shares space in the chest with the heart. The lungs together weigh approximately 2.9 pounds, and the right is heavier. The lungs are part of the lower respiratory tract that begins at the trachea and branches into the bronchi and bronchioles, which receive air breathed in via the conducting zone. These divide until the air reaches the microscopic alveoli, where the process of gas exchange takes place. Together, the lungs contain approximately 1,500 miles of airway and 300 to 500 million alveoli. The lungs are enclosed within a sac called the pleural sac, which allows the inner and outer walls to slide over each other whilst breathing takes place without much friction. This sac encloses each lung and also divides each lung into sections called lobes. The right lung has 3 lobes and the left lung has 2. The lobes are further divided into bronchial pulmonary segments and lobules. The lungs have a unique blood supply, receiving deoxygenated blood sent from the heart for the purposes of receiving oxygen, also known as the pulmonary circulation, and a separate supply of oxygenated blood called the bronchial circulation. The tissue of the lungs can be affected by a number of diseases, including pneumonia and lung cancer. Chronic diseases such as chronic obstructive pulmonary disease and emphysema can be related to smoking or exposure to harmful substances. Diseases such as bronchitis can also affect the respiratory tract. Lung cancer can either arise directly from lung tissue or as a result from a metastasis from another body part. There are 2 main types of primary tumor described as either small cell or non-small cell lung carcinomas. The major risk factor for cancer is smoking. Once a cancer is identified, it is staged using scans such as CT scan and a sample of the tissue or biopsy is taken. Cancers may be treated surgically by removing the tumor, radiotherapy, chemotherapy, or a combination thereof, or with the aim of symptom control. Throat conditions include contusions and fractures. The most common mechanism of injury for a throat contusion or fracture is having the head extended and then receiving a direct impact. In rare cases, swelling or fluid accumulation could obstruct the airway and become fatal. Signs and symptoms include hoarseness, dyspnea, which is shortness of breath or difficulty breathing, coughing, difficulty swallowing, inability to say high-pitched E sounds, and in severe cases, laryngospasms and respiratory distress may occur. The best way to prevent throat contusions and fractures is to wear the proper protective equipment. If an injury occurs, management of throat contusions and fractures starts by trying to calm the person. Try to diminish panic and anxiety, monitor the person, and refer if necessary. Stefan Johnson is a former University of Southern California football player. He was bench pressing 275 pounds on September 28, 2009 when the weight slipped out of his hand and the barbell hit him in the throat. The weight crushed his larynx and it was split into 2 parts. He had emergency surgery to repair the larynx, but it was believed that he would not be able to talk or play football again. He has had several additional surgeries after that initial emergency surgery. He declared for the 2010 NFL Draft after recovering from the injury but went unselected. He signed with the Tennessee Titans as an undrafted free agent but dislocated his ankle in a preseason game and spent his rookie season on injured reserve. In 2012, he sued the University of Southern California for an unspecified damage greater than $25,000. In the lawsuit, Johnson alleged that the former USC assistant strength and conditioning coach was negligently and carelessly inattentive in placing the bench press bar back into the player's hands after an exercise, causing the bar to fall on Johnson and rupture his larynx. This case was settled in 2012. The University of Southern California and the former student-athlete Staffron Johnson resolved the lawsuit, and both parties agreed that the terms and details would remain confidential, so we really don't know what happened. Thoracic conditions include a stitch in the side, pectoralis major strain, sternal fractures, costochondral injury, rib contusions, and fractures. A stitch in the side is also called a side ache, a side cramp, a side crampy, a side sticker, or simply a stitch. This is an intense stabbing pain under the lower edge of the rib cage that occurs while exercising. It is also referred to as exercise-related transient abdominal pain. Some people think that this abdominal pain may be caused by the intestinal organs, like the liver and the stomach, pulling downward on the diaphragm, but that theory is inconsistent with its frequency of occurrence during swimming, which involves almost no downward force on these organs. If the pain is present only when exercising and is completely absent at rest in an otherwise normally healthy person, it is benign and does not require further investigation. Conservative management can include stretching, deep breaths, and rest. The pectoralis major muscle is a large, powerful muscle in the front of the chest. It is used to rotate the arm inward, pull a horizontal arm across the body, pull the arm from above the head down, and pull the arm from the side upwards. It is most likely to rupture at the point where it inserts on the humerus. It is more common in weight training, especially when performing a bench press. The symptoms of a pec major sprain will include a sudden sharp pain in the front of the upper arm near the shoulder where the pectoralis major tendon attaches. There is likely to be rapid swelling in the front of the shoulder and arm. Muscle tests can help reproduce pain and confirm the diagnosis. A visible gap or lump in the muscle may appear. This is commonly known as Popeye's sign. What can an athlete do? They can apply RICE, rest, ice, compression, and elevation, for at least the first 2 days. They can also see a sports injury specialist doctor. A surgeon will operate if it is a total rupture of the tendon. A long rest period followed by a full rehabilitation program is essential. Sports massage may be applied to aid healing after the acute stage. Sternal fracture is a fracture to the sternum located in the center of the chest. The injury, which occurs in 5 to 8% of people who experience significant blunt chest trauma, may occur in vehicle accidents when the still moving chest strikes the steering wheel or dashboard or is injured by the seatbelt. Cardiopulmonary resuscitation, commonly known as CPR, has also been known to cause thoracic injury, including sternum and rib fractures. Sternal fractures may also occur as a pathological fracture in people who have weakened bones in their sternum due to another disease process. Sternal fractures can interfere with breathing by making it more painful. However, its primary significance is that it can indicate the presence of a serious associated internal injury, especially to the heart and lungs. If a person is injured with enough force to fracture the sternum, injuries such as myocardial and pulmonary contusions are likely. Other associated injuries that may occur include damage to blood vessels in the chest, myocardial rupture, head and abdominal injuries, failed chest, and vertebral fracture. Sternal fractures may also accompany rib fractures and are high energy enough injuries to cause bronchial tears or ruptures of the bronchioles. They may hinder breathing. Due to associated injuries, the mortality rate for people with a sternal fracture is high, estimated somewhere between 25 and 45%. However, when sternal fractures occur in isolation, their outcome is very good. Signs and symptoms include crepitus, or a crunching sound made when the a crunching sound made when the broken bone ends rub together, pain, tenderness, bruising, and swelling over the fracture site. The fracture may visibly move when the person breathes, and it may be bent or deformed, potentially forming a step at the junction of the broken bone ends. The upper and middle parts of the sternum are most likely to fracture, but most sternal fractures occur below the sternal angle. If you suspect a sternal fracture, immediate referral to an emergency department is warranted. It is important to rule out associated intrathoracic trauma. The costochondral joints are the joints formed by the ribs and the cartilage which attaches them to the breastbone or the sternum. A separation of the bone from the cartilage is similar to a joint dislocation. This injury may also be known as a separated rib. A separation of one of the costochondral joints usually occurs after an impact, such as a fall onto the side of the body or being hit by something. Violent twisting movements can also result in costochondral separation, and it can also happen from coughing violently. The symptoms of costochondral separation include sudden point tenderness at the point where the rib meets the chest bone or the sternum. Patients often describe a popping sensation. The initial pain may subside only to get gradually worse again. Pain is acute with deep breaths, coughing, and sneezing. Treatment for costochondral injuries is typically rest. Seek medical attention to rule out any complications from fractured ribs or a pneumothorax. Your doctor may prescribe painkillers to ease your discomfort and allow you to breathe more normally. This injury will usually take around 2 to 3 months to fully heal. A rib contusion is a bruise to one or more ribs. It may cause pain, tenderness, swelling, and a purplish tint on the skin. There may be a sharp pain with each breath. A rib contusion can take anywhere from a few days to a few weeks to heal. A minor rib fracture or break may cause the same symptoms as a rib contusion. The small crack may not be seen on regular chest x-rays. Treatments for both problems is the same. You may use over-the-counter pain medications to control pain. Rest, do not lift anything heavy, and do not do any activity that causes pain. You can also apply ice to the injured area every day. The first 3 to 4 weeks of healing will be the most painful. If your pain is not under control with the treatment given, you need to return to your healthcare provider. Sometimes a stronger pain medicine is needed. A nerve block can be done in cases of severe pain. It will numb the nerve between the ribs. A broken rib can injure blood vessels and internal organs. The risk increases with the number of ribs broken. Complications vary depending on which ribs break. Possible complications include a torn or punctured aorta. A sharp end of a break in one of the first 3 ribs at the top of your rib cage could rupture your aorta or other major blood vessels. A punctured lung. The jagged end of a broken middle rib could puncture a lung and cause it to collapse. Lacerated spleen, liver, and kidneys. The bottom 2 ribs rarely fracture because they have more flexibility than do the upper and middle ribs, which are anchored to the breastbone. But if you break a lower rib, the broken ends can cause serious damage to your spleen, liver, or kidney. The internal complications which will be discussed include hyperventilation, pneumothorax, hemothorax, Commotio Cordis, heart contusion, sudden death in the athlete, Hypertrophic Cardiomyopathy, Marfan syndrome, and athletic heart syndrome. Hyperventilation is rapid or deep breathing that can occur with anxiety or panic. It is also called overbreathing and may leave you feeling breathless. You breathe in oxygen and you breathe out carbon dioxide. Excessive breathing creates low levels of carbon dioxide in your blood. This causes many of the symptoms of hyperventilation. Feeling very anxious or having a panic attack are the usual reasons that you might hyperventilate, but rapid breathing can be a symptom of a disease such as bleeding, heart or lung disorder, or infection. It is important to determine the cause of your hyperventilation. Rapid breathing may be a medical emergency that you need to get treated. Often panic and hyperventilation become a vicious cycle. Panic leads to rapid breathing, and rapid breathing can make you feel more panicked. If you frequently overbreathe, you may have hyperventilation syndrome that is triggered by emotions of stress, anxiety, depression, and anger. Hyperventilation from panic may be related to a specific fear or phobia, such as the fear of heights, dying, or being in closed spaces, also known as claustrophobia. It is important to try to stay calm in acute cases of hyperventilation. It may be helpful to have someone with you to help coach you through the episode. The goal of the treatment of the episode is to increase carbon dioxide levels in your body and to work to slow your breathing rate. You can try some immediate techniques to help acute hyperventilation. Breathe through pursed lips. Breathe into a paper bag or cupped hand, but only do this for a short period of time. Attempt to breathe into your belly rather than your chest. Cover your mouth and try alternate nostril breathing. Hold your breath. The symptoms should resolve within 1 to 2 minutes. If they have not, activate EMS. A pneumothorax is a collection of free air in the chest space that causes the lung to collapse. Pneumothorax may occur on its own in the absence of underlying disease. This is termed a spontaneous pneumothorax. Pneumothorax may also occur as a consequence of an injury or underlying lung disease. A small spontaneous pneumothorax may resolve without treatment. A pneumothorax arising as a result of lung disease or an injury requires immediate treatment. Treatment may include the insertion of a chest tube or aspiration of the free air in the chest cavity. A spontaneous pneumothorax is also referred to as a primary pneumothorax. It occurs in the absence of traumatic injury to the chest or known lung disease. Spontaneous pneumothorax is caused by a rupture of a cyst or a small sac or bleb on the surface of the lung. Pneumothorax may also occur following injury in the chest wall, such as a fractured rib, or any penetrating injury, such as a gunshot wound or stabbing, surgical invasion of the chest, or may be deliberately induced in order to collapse the lung. In some instances, the lung continues to leak air into the chest cavity and results in compression of the chest structures, including vessels that return blood to the heart. This is referred to as a tension pneumothorax and can be potentially fatal if not treated. Symptoms of a pneumothorax include chest pain that usually has a sudden onset. The pain is sharp and may lead to feelings of tightness in the chest, shortness of breath or dyspnea, rapid heart rate, rapid breathing, cough, and fatigue. The skin may develop a bluish color, termed cyanosis, due to decrease in blood oxygen levels. A small pneumothorax without underlying lung disease may resolve on its own in 1 to 2 weeks. Control the patient's breathing and activate EMS as soon as possible. The usual cause of hemothorax is laceration of the lung, intercostal vessel, or an internal mammary artery. It can result from a penetrating or blunt trauma. Hemothorax is often accompanied by a pneumothorax, sometimes called a hemopneumothorax. Hemorrhage volumes range from minimal to massive. Massive hemothorax is most often defined as the rapid accumulation of greater than 1,000 milliliters of blood. Shock is common. Patients with large hemorrhage volumes are often dyspneic or have trouble breathing and have a decreased breath sound. They may also have rapid breathing rate or tachypnea, pain, and may be turning blue from hypoxia or the lack of oxygen reaching tissue. Control breathing, treat for shock, and activate EMS as soon as possible if a hemothorax is suspected. Commotio cordis is an often lethal disruption of the heart rhythm that occurs as a result of a blow to the area directly over the heart at a critical time during the heartbeat, causing cardiac arrest. It is a form of ventricular fibrillation, not mechanical damage to the heart muscle or surrounding organs, and is not the result of heart disease. The fatality rate is about 65%. It can sometimes, but not always, be reversed with defibrillation. Commotio cordis occurs most frequently in boys and young men the average age of 15, usually during sports, most often baseball, often despite chest protectors. It is most often caused by a projectile, but can also be caused by a blow of an elbow or other body parts, such as a fist. Being less developed, the thorax of an adolescent is more likely prone to this injury given the circumstances. Commotio cordis is a very rare event, but nonetheless is often considered when an athlete presents with sudden cardiac death. Some of the sports which have the risk that cause this trauma are baseball, association football, ice hockey, polo, rugby, football, cricket, softball, pelota, fencing, lacrosse, boxing, karate, kung fu, and other martial arts. Children are especially vulnerable, possibly due to the mechanical properties of their thoracic skeleton. From 1996 to spring 2007, the USA National Commotio Cordis Registry had 188 cases recorded. Almost all occurred during sports. 96% of the victims were male, and fewer than 1 in 5 survived the incident. Look for athletes who were hit in the chest by an object, such as a baseball, baseball bat, lacrosse ball, or a fist. There should be no apparent trauma. The athlete will typically stumble forward for a few seconds, which is followed by unconsciousness, no breathing, and no pulse. An AED will indicate that the athlete is in ventricular fibrillation. Factors leading to commotio cordis include the timing of impact, which refers to the timing of the object hitting the chest during the cardiac cycle. The heart is most vulnerable when it's struck at the beginning of the T wave. This part of the cycle indicates the refilling of the heart's ventricles. Use an AED and defibrillate as quickly as possible. For every 1 minute delayed in getting shocked by the AED, there is a 10% decline in survival rate. Using the AED is the best practice and gives the athlete the greatest chance of survival. Immediately activate EMS or the school's emergency action plan. Continue AED use and CPR until EMS arrives and takes over. Blunt cardiac injury, a general term to describe all non-penetrating injuries to the heart during trauma. It incorporates myocardial or cardiac contusion, structural injuries such as valvular damage, and traumatic pericardial effusion. Blunt cardiac trauma usually results from a high kinetic force that travels through the thorax into the heart, most commonly high-speed motor car accidents. Signs and symptoms include blood and fluid leaking into surrounding tissues, decreased circulation to the heart muscle, hypoxia, and necrosis in the heart, which is cell death, localized pain, and referred pain to the left shoulder. They're going to exhibit symptoms similar to a heart attack. We need to activate emergency medical services immediately. Low blood flow to the heart can result in catastrophic injury. Hypertrophic cardiomyopathy is a disease in which the heart muscle or myocardium becomes abnormally thick or hypertrophied. The thickened heart muscle can make it harder for the heart to pump blood. Hypertrophic cardiomyopathy often goes undiagnosed because many people with the disease have few, if any, symptoms and can lead typically normal lives with no significant problems. However, in a small number of people with HCM, the thickened heart muscle can cause shortness of breath, chest pain, and problems in the heart's electrical system, resulting in life-threatening abnormal heart rhythms, or arrhythmias. Hypertrophic cardiomyopathy is usually caused by abnormal genes that cause the heart muscle to grow abnormally thick. The severity of hypertrophic cardiomyopathy varies widely. Most people with HCM have a form of the disease in which the wall or the septum between the two chambers of the heart or ventricles becomes enlarged and impedes blood flow out of the heart. This condition is sometimes called obstructive hypertrophic cardiomyopathy. Sometimes hypertrophic cardiomyopathy occurs without a significant blocking of the blood flow. However, the heart's main pumping chamber, the left ventricle, may become stiff, reducing the amount of blood that the ventricle can hold and the amount that gets pumped out into the body with each heartbeat. This condition is sometimes called non-obstructive hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is typically inherited. There's a 50% chance that children with a parent of hypertrophic cardiomyopathy will inherit the genetic mutation of the disease. The signs and symptoms of hypertrophic cardiomyopathy may include one or more of the following: shortness of breath, especially during exercise; chest pain, especially during exercise; fainting, especially during or just after exercise or exertion; sensations of rapid, fluttering, or pounding heartbeats or palpitations; and a heart murmur, which a doctor may detect while listening to your heart. Patients diagnosed with hypertrophic cardiomyopathy should be disqualified from sports participation. Athletic heart syndrome is a heart condition that may occur in people who exercise or train for more than an hour a day, most days of the week. Athletic heart syndrome isn't necessarily bad for you if you're an athlete, and is not what makes young athletes expire mid-court. While it does lead to structural changes in the heart, a person with this condition usually does not notice any other symptoms. Athletic heart syndrome does not require treatment and is important to diagnose only to rule out other heart problems that may be serious. Like other muscles, the heart gets stronger with exercise. Endurance exercise such as jogging, swimming, and cycling can make the organ bigger, allowing it to pump more blood with every beat. Short, intense workouts, such as weightlifting, can further increase the pumping power by the thickening of the walls of the heart. Just as bodybuilders sculpt their abs and biceps into highly defined muscles, competitive athletes may develop extraordinary hearts as well. Not only is the heart extra large and thick, it may also produce some irregular rhythms, or arrhythmias. A person with athletic heart syndrome may also have a markedly slow resting heart rate, in the range of 35 to 50 beats per minute. In addition, electrical impulses can take strange routes across the heart, causing abnormal readings on an EKG. Together, these changes produced by exercise are called athletic heart syndrome. There are no symptoms other than bradycardia or low heart rate. After all other heart conditions are ruled out, no treatment is necessary for athletic heart syndrome. Marfan syndrome is a genetic disorder of connective tissue. The degree that people are affected varies. People with Marfan tend to be tall, thin, with long arms and legs, fingers, and toes. They also typically have flexible joints and scoliosis. The most serious complication involves the heart and the aorta, with an increased risk of mitral valve prolapse and aortic aneurysm. Other commonly affected areas include the lungs, eyes, bones, and the covering of the spinal cord. There is no cure for Marfan syndrome. Many people have a normal life expectancy with proper treatment. Management often includes the use of beta blockers. Surgery may be required to repair the aorta or replace a heart valve. It is recommended that hard exercise be avoided. About 1 in 3,000 to 10,000 individuals have Marfan syndrome. Marfan syndrome occurs equally in males and females. Rates are similar between races and among different regions of the world. The signs and symptoms of Marfan syndrome vary greatly, even among members of the same family. Some people experience only mild effects, while others develop life-threatening complications. In most cases, the disease tends to worsen with age. Marfan syndrome features may include tall and slender build, disproportionately long arms, legs, and fingers. If you stick your thumb inside your fist, if there's a part of your thumb that sticks out on the other side by your pinky, you could have a Marfan's trait. The breastbone that protrudes outward or dips inward, a high arched palate or crowded teeth, heart murmurs, extremely nearsightedness, an abnormally curved spine, and flat feet. Because Marfan syndrome can affect almost any part of your body, especially the connective tissue, and may cause a variety of complications, it is therefore a disqualifying condition.